And we already talked a little bit about these challenges, but my next question would be, what are the common challenges faced on the program? So I know you have some things to talk about. We already touched some of the subjects, so
Yeah,
if you want to just
sure,
kind
sure.
of go through them.
Yeah, yeah. They're kind of like five main things, and these are actually, yeah, these are things I've mentioned before, but I'll touch on them again. I think the first thing is clinical reasoning, and people love talking about clinical reasoning. It's a big part of the courses, but there are always ways to get better at that. And so a big part of the diploma program is to heighten that clinical reasoning and to make people realize that to do our job as best we can, we do want to be as efficient as possible. So we could ask someone 100 different questions during the history taking, right? I could ask you, Mariana, what's your eye color? And do you prefer morning or evening? Like all kinds of like silly questions I could ask you, but I'm not going to because it's not relevant to if you let's say I'm seeing you for neck pain. Your favorite color is not part of your neck pain, right? Um, and so along those same lines, it's so easy to ask too many questions. And I think, people go through the courses part A through D, and as they do that, they become more and more proficient with the form. So they learn the form and they get excited by the form. And then when they get good at the form, they want to use what they're good at. But now in the diploma program, it's like, okay, you're really good at the form, but now we almost have to sort of let go of the form a little bit or only use it for the things that we need. It's okay to not ask every question. If you've asked every question, you've asked too much, guaranteed, right? There's got to be some blank, there's got to be some empty space on that form. And how do we ensure that? Well, we ensure that by asking every question for a specific reason. If I'll ask you your age, why? Because age on its own is going to tell me, is this more likely, or is this classification more likely, or is that classification more likely, right? And then I'll ask you where the pain is. And right away from that question, pain location, we should be able to eliminate a lot of different classifications. So with each question, we're eliminating more and more classifications, very much like a funnel, right? We're starting with all these options, and then with every question, we're funneling down. Once again, people listening to this can't tell, but I'm creating a funnel image with my hands. Um, and by the end of the history, there should really only be two, at most three potential classifications. And it's surprising how often people aren't used to that kind of process. Their first week doing the diploma, we might finish the history and then we'll excuse ourselves from the patient. We go out into the hall and say, okay, so based off of that, what do you think are the potential classifications? And I'll say, oh, well, maybe dysfunction, maybe derangement, postural, but unlikely, maybe MURS. I'm like, whoa, hold on. There's no way it could be all these things, right? Guaranteed there are things in history that have already excluded some of these. And so it becomes really important to keep track of those questions, to make every question intentional. We're not just filling out the form, there's got to be intent behind it. And so when we get smart with that and good with that, oh, we can save so much time. Like you can finish a history in 5 minutes sometimes. Sometimes, usually 10 at most. There are some people who you can tell, oh, this person needs to talk. It's going to be part of their physiotherapy will just be kind of letting out all this kind of emotional stuff. Great. Then sometimes I'll chat with someone for 25 minutes and I know that it's not really part of the history, but it's part of the therapy. We've already started doing therapy just from chatting, but those are more exceptional cases. Usually within, 10 minutes, max 15, you finished your history. And that's for a lot of folks, they are not used to that kind of time frame. They come in and their history is 25, 30 minutes. So it's just too many questions being asked. And of course, part of that also is how clear is your question? It's so easy to ask an ambiguous question. So learning how to make things very clear, unambiguous will save you so much time, will help for your clinical reasoning. And then of course, the physical exam, how does that help you for that clinical reasoning as well? And that brings me into the next thing that people learn is assessment. Like how do you actually do the physical assessment? And it's funny because in MDT, we're actually not assessing that much. right? When you think about other approaches where they're looking at, muscle co-contractions and stability of certain musculature and all these special tests and XYZ, MDT, we're really looking at range of motion. We're doing some observation. We might do a neuro exam. We might do some strength testing, and then we do the repeated movement testing, right? That's it. And sometimes we don't need to do the neuro, and sometimes there's no reason to do strength. So sometimes all we're doing is range of motion. Often we'll try to get some functional baselines and then repeated movements. Compared to other approaches, this is a small physical exam, but it's surprising how even though it's kind of small and limited, we have to do it right. We've got to do it absolutely right, correctly, precisely, so that the information is valid. And it's surprising how a lot of folks actually struggle to do it with that kind of precision. So they say, yeah, I did my range of motion testing, but if it's a little bit sloppy, well, we don't know, hey, did that person have pain during movement or end range pain? Okay, you don't know. Well, if you don't know, then now there are options on the table that shouldn't be on the table. If it's pain during movement, now we know it can't be dysfunction.